Yeah, we have to have clear the logistical thing. We need that the patient have a joint caregiver that be with him the 24 hours of the day. We also need that the patient stay at within 30 minutes from the hospital, and to really know how to recognize these signs and symptoms of alarm and these side events, and they will call us if they have any trouble, and they have to come to the hospital if they have any problem. We have to be sure of all these things. Mm-hmm. And so when we are confident with all these things, we let them start the program with us.
Welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA. I am your host, Isabel Olivera. In today's episode, we are going to learn about how to deliver CAR-T therapy in a fully outpatient setting. For this, we are joined by Dr. Alexandra Martínez Roca and Dr. Beatriz Merchan Muñoz from the Hematology Service at the Hospital Clínic de Barcelona in Spain. Thank you very much for being with us today.
Thank you for inviting us.
And can you please, first, Dr. Martínez Roca, can you please introduce yourself?
Well, I am an hematologist at Hospital Clínic of Barcelona and do mainly of my work in the at-home unit that is specialized in hematological and oncological patients. And I also do most of my research in acute myeloid leukemia.
Thank you. And Dr. Merchan Muñoz, can you please introduce yourself?
Hi, yes, I am Beatriz. I also am a hematologist and work with her at home unit. I'm more specialized at advanced therapies at home and making it possible to do it outpatient.
So we believe that delivering CAR-T in an outpatient setting is a very rare thing in Europe. To our knowledge, it's only happening in your hospital. So we're really glad that you're here to explain to us how you can do this. So to start off, Dr. Martinez, can you please take us back to the beginning? Can you briefly explain what was the history of your unit before delivering CAR-T to outpatients?
So our unit was born in the year 2000. We just celebrated our 25th anniversary. With the project led by our boss, Dr. Frances Fernandez Avilés. He wanted to deliver outpatient autologous transplant, the follow-up of the aplasia. So he with the project, he started a project where he compared patients in the doing the transplant as inpatient versus patients that did the whole aplasia as outpatient, and he proved that it was safe, that patients were more satisfied, and that there was an important saving in cost as doing it that way. That was the beginning, and since then the unit continued to grow. After that, they started at the time we were in there, but they started with follow-up of aplasia after high-dose chemotherapy, delivering arsenic tiouricide for promyelocytic leukemia. And we kept growing, Veneza for acute myeloid leukemia patients, the first cycle at home. And in the recent years with CAR-T cells and biospecifics also at home. So we have a long history of experience, not only doing at-home management, but also teaching other hospitals and how to also do this. So there's a lot of experience in other centers in Spain that have learned from our own experience. And they're also doing at-home autologous transplant and other therapies.
When did you start doing CAR-T therapy in an outpatient setting in your clinic?
Yes, well, CAR-T cell we started doing CAR-T cell in our center in the year 2017 with our own construct, ARI. And at that moment in Spain, there were no commercially available CAR-T. A few years, like I think 2018 was the first year that we had the first commercially available. And we started doing early discharge CAR T cells with CAR T cells in the year 2019. After 2 years of doing inpatient CAR T, I think the whole team felt comfortable in starting to do an early discharge. But that time, the guidelines required for patients that were after receiving the CAR to be in the hospital for 14 days. So we decided to start shortening this time, and those patients that were stable, and that was our first experience for patients that were stable after receiving our card has 3 doses. So after the 72 hours after the 3rd dose, we will take the patients back home with our unit. And it was a really good experience to start managing side effects or seeing if the whole the training of the nurses and having some experience to go into the next steps.
What changed in the recent years that has make outpatient CAR T more feasible, more safe than when CAR T therapy started?
Well, first, I think in most centers you have to have a learning curve when you start doing a new therapy. So everyone has to do some training, and I believe that in our center, after 2 years of delivering CAR T cell, there was enough training, and we already knew how to manage most of the side effects of CAR T cell. Also, there was a lot of improvement in the grading of the side effects worldwide. Like there were a lot of different grades at the beginning, so you didn't know what to use. But then when there was a consensus, we had really good tools evaluating the side effects of the patients, cytokine release syndrome and immune effector neurotoxicity. So I think it was easier for us to detect and sometimes even try to predict what patients were going to be more prone to have the side effects, and also being more frontline in managing, like not waiting for the patient to be like in a bad shape, but just doing it promptly. So that also allowed us to be sure of if we have a patient at home and he has a problem, what we're going to do. Also, I believe the team of nurses was also well trained, and we had like new figures, like as we have this nurse that is managing the patient throughout the whole journey. That is it's called EHA in Spanish. That's like advanced practice nurse, and this also helped us to have a control of all the other things that we don't see that are really important for at-home management, like the location of the patient, the caregiver, or what type of economical problems the patient can have that for having the patient as outpatient. And I think those were the main improvement that we had, I think, in our hospital and also worldwide managing CAR T cells.
Can you, Dr. Merchan, explain how the fully ambulatory home management started also, and how does it work?
Okay, so as we had this great experience with early discharge, we were comfortable enough to start our infusion outpatient. As Alexandra told us before, we have our own construct that is infused in 3 aliquots. And in myeloma patients, we also do an extra infusion at 3 months for patients that are at least at partial response and that have not had severe complications before. So this is called like a booster dose. And in the clinical trial, they used to administer this booster dose in patients, and they were there for like 4 days to monitor the patients. So we ask ourselves, so if they really need to be at the hospital monitoring their patients. And that's why we started this at-home outpatient full ambulatory administration with a booster dose. And we do this program with our at-home structure program that was already started. And we do this booster dose at the infusion was done at the day hospital, and then if the patient was stable, after an hour he could go home, and we continue the monitoring at home. We have to do this training before the patient is admitted with the at-home unit. We have to visit the patient and also the caregiver, and we make a plan. We teach them how to recognize the vitals, the signs that they have to call us if they have any problem. And when we are clear and we see that everything is working, we let the patient be admitted in our unit, and we do the infusion at the hospital, and then we continue the control at home.
Does this mean that if you feel that the home setting is not supportive enough, some patients will be treated at the hospital, and some others will be treated in the fully ambulatory setting?
Yeah, we have to have clear the logistical thing. We need that the patient have a joint caregiver that be with him the 24 hours of the day. We also need that the patient stay within 30 minutes from the hospital, and to really know how to recognize these signs and symptoms of alarm and these side events, and they will call us if they have any trouble, and they have to come to the hospital if they have any problem. We have to be sure of all these things. And so when we are confident with all these things, we let them start the program with us.
And then some other patients will receive the treatment at the hospital, the ones that you are not fully confident about?
Well, we are training them, and in the end, we always, because we do this with many weeks before they have to do the infusion, so in the end, many patients are trained, and we are confident enough to do this with them at home.
We try to, most of the issues with patients are logistical. The lack of a caregiver, or they are not close enough to our hospital. So we work with different foundations that have flats near our hospital to bring them close. And we also work with professional, we have a program that is also with ONG, with professional caregivers that are trained to be with this type of patients and detect all the problems. So we do our best for the patient to do it as outpatient, but if none of this is possible, then he will come in. But we try our best the most part, logistical part, I think, to try to do it as outpatient. And of course, we have a logistical and medical criteria for patients that can be selected to do it at home.
So what are these criteria? How do you select these patients for the outpatient setting?
So the logistical criteria are these that we've told you, and the clinical ones is that he has to have an ECOG performance status below 2. They have to don't have any major organ dysfunction, and also we measure the Burkitt disease. If they have a Burkitt disease that have risk of make effect mass, we do it in hospital. And also if they have a high tumor burden that is so associated with having more side effects and more severe, we do this patient in hospital, and we try to early discharge if we can. And all of the rest, we try to do outpatient. So we started with the booster dose, and with this experience also was so great. We do more than 40 nowadays, and we have no admissions and no severe complications. So with this great experience, we later started with the full outpatient infusion from the beginning. So we started with our academic products for acute lymphoblastic leukemia, and also for multiple myeloma with our academic. And some months ago, we started with commercial cards also. So nowadays we have done like 32, and we have not had severe complications, and the patients are well and safe at their at their houses.
What proportion of patients do you think fall into the criteria to be able to be treated at home then?
So nowadays it's like 1/3 of the patients that are treated at home, and the other 2/3 are in hospital. But as we said, we try to discharge them earlier.
So what does your outpatient surveillance look like once they are at home? How do you survey?
So the nurses are the one that are doing the telephone calls. So we tell them before that they have to have the thermometer, the blood monitor, the blood pressure monitor, and also the pulse oximeter. And they have to know the ICE score in order to know if they have some neurotoxicity. So the caregiver have to do this in the morning and in the afternoon. And if they have any trouble, maybe they have to do it more times for the day, but at least in the morning and in the afternoon. And the nurses call them and to check all these vitals and if they have any problems. And we make sure that if they have any problem, they cannot wait to the call. They can call us whenever they have any doubt. There's no call that is unnecessary. We make sure that they know that they can call us at the night whenever they want. And so if everything goes okay, we keep this monitoring at home and we do lab tests at like 28 hours or every 72 hours in order to make sure that the patients and all the parameters are okay. And if they have any problem, they have to call us and come to our hospital because we have a 24-unit support where we can validate them and value them and check if anything is wrong and make the treatment that they need in this case. So this unit is always attended by an hematologist that knows all these patients and this program.
So what impact does this setting have on the hospital resources?
So with all this structure, we could free up the beds earlier because the patient with the early discharge in the beginning stay less days at hospital. So we liberate these beds and also we reduce hospital cost. And with the full outpatients, we free up earlier the bed, like 14 days maybe. And we reduce the cost. And also the more valuable impact is that the patients that usually are heavily treated patients are at home. They can sleep in their houses, be with their family, and I think this is not measurable.
What tips would you give a center that wants to start an outpatient setting for CAR-T?
First, you have to see what country are you in and what's the legislation on outpatient management or at-home management, because it's not the same in every country. And there are some countries that cannot give blood products outside of the hospital. So you have to be aware of what's the legislation. And then you have to see what resources do you have. Do you have enough nursing? That is a big problem in Europe and I think worldwide. To start a program, and also do you have the resources to train them, and also to have a physician that is in charge of this, of a program, because I think part of our success is that we are fully dedicated to this, so we rapidly detect anything that is not going well or anything that we need to change, and that's what's helped us to make it a safe program. After that, after the resources, you have to have clear indications for the patient and for the physicians and all the nursing staff on when the patient has to consult, on when the patient have to call, and how you're going to manage the patient. Is it going to come to a special unit as we have, or is it going to come through the ER? Is it going to be prioritized in the ER? So this is really important. And after that, if you start this program and you have everything, to keep continuously evaluating your results. Is this really safe? Is the patient comfortable? If the caregiver comfortable also. See but sometimes we're as doctors, and we are so focused in the medical part that we forget the patient, the psychological and family for both patient and caregiver. And there are, for caregivers, is maybe the patient is really happy to be at home, but for some caregivers, there's a lot of work in taking care of their loved ones, and they do it with all the love, and they're really happy, but it's also a lot of work. So that's for us it's really important also to take care of the caregiver, and I think, and if you have all the elements, it's really important to be, as we were discussing before, it's really important for the people to feel comfortable doing this, especially the health workers, because we are not used to doing outpatient things. It's really hard to convince people to do this. So I think a good training and having all the thinking in advance of what can happen and try to plan how to confront it is really important. But I think this will be the steps on starting a new program, an outpatient or at-home program.
Now that you have this experience, what innovations, what could make this easier? So which innovations in CAR-T could make this easier?
Well, we have there have been some publication on telemedicine. Well, we do telemedicine with telephone, but with remote monitoring, and we have been exploring this. The problem is that when you start monitoring someone, that sometimes can create some anxiety on the patient. And also, you have to be sure of who's going to be in charge of checking those alerts. So we haven't gone there. Sometimes we think that with patients that present any complication and we send them back home after they are stable, it will be nice, or it will be a good tool to have them with monitoring during 24 to 48 hours. Mm-hmm. Also, I think trying to predict who's going to have complications, that will be amazing. I think maybe AI can help us with this, with trying to maybe models that can predict more feasible, more
accurately.
Accurate, yeah, that's the word. More accurate, what patients can maybe. So that will help us a lot with the selection of the patient. Because we had some cases that they were like perfect in paper, like they didn't have any burden disease, and they were MRD negative, and they did present with some complication that we didn't expect it. So that will be great to have better tools to detect, and also I think better resources for this. Like for people to be aware of that this is the future. I think the lack of hospital beds is really present everywhere, and we don't have a space in Barcelona. We don't have a space for having more beds, and most of the hospital is really hard, and the patients are really safe. That we have great caregivers that can take care of them, and also. It's a way of empowering also the patient in taking care of also being part of the decisions that are happening with his health. And I don't know if you have anything else.
I'm agree with you.
And I think, yeah, probably those are the advances that we need in order to keep improving.
Mm-hmm. So what would be your takeaway message? What should hematologists take away about delivering CAR-T in an outpatient setting from this podcast? What do you not from this podcast, from your experience, what should they take home?
So we encourage them to have these options in mind mm-hmm. and be confident to start this program with an structured at-home unit. And that it could be safe and worthy for the patients.
Yeah, there are already a few, I think, over more than 5 of publication on outpatient management in the United States, and it show that it's safe, that is feasible, that is cost saving, and in our experience is also happening. It's also like this. That is probably the main concern is the safety. So we can tell if you have clear indication on when the patient has to come and a good pathway for them coming back, it's completely safe. And also if you do a good training, both the patient and caregiver and all the health personnel, it's also completely safe. And also it can help both keeping the timing when the patient has to come in to get the car, because if you don't have beds, sometimes you have to delay the patients so they can come in. It can help with timings. It can help with the amount of patient that you can treat also, and I believe it can be a starting point to doing other things like biospecific at home. Follow-up of aplasia at home. This can be a good experience, or even autologous transplant at home could be a good starting point to doing other type of hematological procedures at home or outpatient.
So thank you very much for being with us today. It's been a very interesting conversation. And I hope this inspires other people to try this setting, or at least inspires them to think about it. How could they manage this in their own hospitals?
Thanks for the invitation.
This podcast has been made possible by an unrestricted grant from BMS. Thank you to the audience for listening. And if you like this episode, please subscribe to our channel. Stay tuned for more episodes of EHA Unplugged.